You'll be in her shoes before you know it. About September of next fall, then you'll be going, oh my goodness, I can't believe I'm getting ready to graduate. I still have so much to learn, and that's normal. Okay. So it's 6 o'clock, so I'm going to go ahead and get started. This is a long presentation, 47 slides, and there's a lot of material, and I don't want to rush you, so I'll get through it as quickly as I can, but I also want to give you time to ask questions and digest some of the material. So we're going to do this as a case study tonight, so I'd like you to participate and answer questions as I go along, so I can try to help you understand this a little bit better. Okay, so we're going to talk about a patient, Mr. Stewart. This isn't a real patient. It's based on a real patient, but it's not a real patient, so I'm not breaking any HIPAA rules, anything like that. But let's call him Mr. Stewart, and he's a 58-year-old white male who presents to the clinic for a physical exam. His chief complaint is that he's just been feeling tired lately, and he denies seeing a provider for the past 8 years because he lacked health insurance. He was seen by the clinic triage nurse last week, and standard labs were drawn. At that time, his blood pressure was 144/94. His past medical history, he had usual childhood illnesses and no serious illnesses as an adult. He hasn't had any surgeries or hospitalizations. He's not currently taking any medications. He doesn't have any drug or environmental allergies, and his last immunizations were when he was in the military about 30 years ago. He's got some catching up to do. His social history is that he smoked when he was young but quit about 15 years ago. He has an occasional beer, 2 or 3 at a time on the weekends. He denies any regular routine exercise. He's worked sporadically as a night watchman and is currently unemployed. He's married and lives with his wife and mother-in-law in a rental apartment. Pets include 1 dog and 2 cats. He does not have health insurance, and he receives food stamps. His family history, his mother had diabetes and hypertension. His father died of an MI at age 54. His brother has hypertension, and his sister has obesity and diabetes. So first, let's go through the review of systems and tell me what kind of things you would want to ask. This is the first time you're seeing him, okay? So does he have chest pain or shortness of breath? Okay. Vision, okay? Let's go head to toe. Vision, you want to know about vision. Constitutional, May says ask about weight gain and or what? Weight gain or weight loss, either one, weight gain or loss. Increased thirst, increased urine, polydipsia, polyuria, any hot or cold intolerance. Those are all good. So we've kind of done constitutional. For HENT, we've asked about vision. Anything else about HENT? Sores. How about HENT? Anything else that you want to ask him about that? When's the last time he went to the dentist? Okay, dental care. Does he have any problem with ear infection? Does he have any changes in his hearing? Good. Okay, does he have headaches? I think you mean eye exam, probably last eye exam. Any difficulty swallowing, any yeast infections or candida? Very good. Blurry vision or changes in vision? Okay, so we've done the constitutional HENT, somebody for chest, somebody heart and lungs, somebody said chest pain and shortness of breath. Anything else for heart and lungs? Okay, for skin, dry skin, palpitations. For skin, somebody says skin changes, rashes, and discoloration. Dorcas says swelling or edema. That's right with the heart and lungs. How about with the lungs? Said ask about shortness of breath. Anything else? Shortness of breath, cough. Okay, history of asthma, okay, cough or night sweats, infections, claudication, okay. So we've talked kind of about cardiovascular, respiratory, and some vascular stuff. How about GI? History of pneumonia, okay. Abdominal pain, nausea, vomiting, diarrhea. Any problems with the liver, any constipation, what his bowel habits are, things like that, okay. Stools, musculoskeletal. Any pain, body aches, joint aches, things like that. He's 58, I think, so he might be getting some of those. Weakness, okay. May says ask him about diet, very important. So for review of systems for his, most of the systems we've already talked about. We talked about skin, so psych, history of psychiatric problems, depression or anxiety, more neuro, numbness and tingling, memory loss, important to ask. And we've already talked a little bit about social history as far as his drinking and his exercise, lack of exercise. Okay, so let's go and look at what he said for. Oops. So review of systems. Constitutional, he denies any fever. He's had positive fatigue for 1 year. He's had a gradual weight gain over the past several years. His hair and skin, he has dry skin. He has thinning hair with male pattern baldness. HENT, his last eye exam was about 20 years ago. He wears readers from Walmart. He has occasional blurry vision. No complaints of headache, dizziness, earaches, nasal congestion, or sore throat. Last time he went to the dentist was 8 years ago. Heart and lungs, he denies chest pain, shortness of breath, cough, night sweats, claudication, or any history of DVT. Hematology, he denies any history of anemia or bleeding disorders. GI-GU, we forgot to talk about GU. No nausea, vomiting, diarrhea, occasional heartburn, relief with Maalox, daily BMs, no tarry stools, no history of having a colonoscopy. He does have frequent voiding 2 to 3 times a night with a strong stream. And in a male, any male this age, you want to ask about ED, and you want to ask about urinary stream and any problems with that. And then endocrine, no thyroid enlargement or tenderness. He is bothered by cold, and he has positive for polyuria and polydipsia. Musculoskeletal, he complains of frequent low back pain, and he takes Motrin for that, and he denies any limitations in range of motion. Neuro, he denies any seizures, syncope, or decrease in sensation. Psych, he admits to mild depression over financial concerns. His 24-hour diet recall: breakfast, 2 eggs, bacon, grits, orange juice, and 2 cups of coffee. Lunch, a Whopper with cheese, large fries, and a large Coke. Not too good here. Dinner, fried chicken, mashed potatoes, corn, bread, sweet tea, and ice cream for a snack. We've got some education to do. Okay, so what systems would you want to examine, and what specifically would you be looking for? Okay, before we get to Christy's saying labs, let's not get to labs yet. So eyes, ears, mouth, neck, thyroid, what kind of things are you going to be looking for? Okay, Brittany's saying labs, ketones. We'll do labs in a little bit. Vision loss, okay, you're going to look at the eyes and look at the vessels, good. The mouth, look at the condition of his teeth, any caries, look at the condition of his gums, look at his palpate his thyroid, see if it's enlarged or tender, look at his skin. Neuropathy, do a foot check and check for sensation, check his feet. Okay. How about heart and lungs? So physical exam. obviously you're going to get, have somebody do the vitals when he gets there. His weight is 210 pounds, height 5'9", giving him a BMI of 31, heart rate 82, respiratory rate 16, and his blood pressure is 145/93. And remember, you have that other blood pressure from last week. I think that was 144/94. General, he's a well-developed, obese white male and no apparent distress. He seems to be a reliable historian. He's alert and articulate. His HENT, his pupils are round and reactive to light and accommodation. ELMs are intact. He's unable to read a paper without glasses. Ophthalmoscopic exam, his lens are clear, discs are sharp, no exudates or hemorrhages. Ears, the TMs are pearly gray and able to hear a whisper. Nose, his nares are patent, no drainage. His mouth has poor dental hygiene with 2 obvious caries. Tonsils are 1+ without exudate or erythema. His neck is no enlargement of the thyroid, no tenderness or nodules felt. I always want to listen for carotid bruits when you examine the neck. He does not have any carotid bruits, and somebody mentioned the skin discolorations. He does have acanthosis nigricans, or the dark brown skin on the back of his neck. Cardiorespiratory, his heart rate is regular rate and rhythm, no murmurs, lifts, or heaves, normal S1 and 2, lungs are clear bilaterally. Pulses are 2+ in the upper extremities, 1+ in the lower extremities with no varicosities. His abdomen is obese, non-distended, non-tender with no hepatosplenomegaly, no hernias or masses, bowel sounds are positive, doesn't have any bruits over the abdominal aorta or renal arteries, no CVA tenderness. He does have purple striae on his abdomen. GU is deferred. Lymph nodes are negative for adenopathy. Musculoskeletal, he has full range of motion of all extremities with good strength. His neuro exam, CN 2-12, are grossly intact, negative Romberg, normal gait, CTRs are 2+. His foot exam, he has warm feet, pedal pulses are 1+, he has calluses to his heels, and he has positive sensation to the monofilament in 5 areas. Okay, so we did some screening labs at the week before, and someone up here talked about different kinds of labs you would get. For internal medicine, most of the time, somebody this age complaining of fatigue, you're going to do a CBC to look for anemia, a CMP to look for renal function, and electrolyte disorders and diabetes. LFTs to make sure he doesn't have any problems with the liver, a lipid panel to see where he is with cholesterol, A1C to screen for diabetes, TSH because he's complaining of fatigue, urinalysis. So let's go over those. His CBC was within normal limits. His CMP, his fasting blood sugar was 189. His creatinine was 1.1. Everything else is normal. LFTs were normal. His lipids, his total cholesterol is 240. Is that okay, or high or low? I know you haven't had your lipid unit yet. That's on the high side, okay? You want to see your total cholesterol under 200. Okay, LDL is 148, high, low, in between. That is high, okay? I'd like to see LDL under 100. HDL 36, high, low, it is low, okay? You want to see HDL about 50, so his is low, and that is a positive independent risk factor for heart disease. And triglycerides 189, high, low, those are high, okay? 150 is the limit for triglycerides. So he has dyslipidemia. A1C 8.2, high, low is high. TSH 4.4, high, low, it is high. Everybody's just saying hi to everything because he's high on everything. And urine 2+ glucose, which obviously you shouldn't have any glucose. And random finger stick glucose that was done at triage last week was 210, which again is high. Okay, so any other tests that you would want at this point, knowing what you know so far? Okay, a T4, free T4. An EKG would be good to get a baseline EKG because he really hasn't had any care, and a microalbuminuria test for microalbuminuria. Good. Okay, so additional labs, free T4, and the results are 0.5. Normal is 0.7 to 1.9, so it is low. Random spot urine for albumin to creatinine ratio is 65, and that is high. Above 30 is considered to be microalbuminuria. Okay, so let's list what your diagnoses are based on his lab values and his vital signs. Okay, diabetes type 2, hypothyroidism, hypertension, hypercholesterol, hyperlipids or high cholesterol. All right. Anything else? Something you're going to code for. Metabolic syndrome, obesity. Yeah, obesity. Okay. So he has type 2 diabetes, dyslipidemia, hypertension, hypothyroidism. Remember, his TSH is high, his free T4 is low, his pituitary is trying to get that thyroid to work, so it's pushing out that TSH. He has obesity. He has microalbuminuria, so his kidneys are at risk. And he has risk factors for arteriosclerotic coronary vascular disease because he's got high blood pressure, he's got a low HDL, he's obese, he's got high lipids. Okay, so first we're going to talk about some of the goals of treatment for him and what your recommendations would be, what medications and what referrals. But we're going to take it one step at a time. So for everybody, what are going to be the lifestyle recommendations? Diet and exercise, okay? Weight loss, diet and exercise. How much exercise do you recommend? Obviously start slow, but what is it? 30 minutes a day, 5 days a week is going to be your goal. You don't want to say, you have to go out and start doing that tomorrow, but start with walking or something like that. Okay. We're going to talk about medications and referrals in a minute. What's going to be your A1C goal for this patient? Okay, less than 7. Okay. We're going to look at the ADA, ADA approach to setting your A1C goal, because it's not one size fits all. And I see that some students have been putting the ACE guidelines, American Academy of Clinical Endocrinologists, which is great, but there are 2 sets of guidelines, and I don't want you to get confused. The exam is written on ADA guidelines, so those are the ones we're going to go by. ACE guidelines are a little stricter. Their goal for A1C is less than 6.5. ADA feels that for most patients that might cause more hypoglycemia. So when you're thinking about patients and where you're going to set the goal, you want to look at several different factors, and I think both ACE and ADA do this. So you want to look at their risks for hypoglycemia and adverse drug reactions. You want to look at how long have they had the disease. If they're newly diagnosed and have very few complications at this point, you're going to be more aggressive with them. If they've had diabetes for 20 years and they've been in poor control and have a lot of other complications, you're going to be less stringent because they're going to be more fragile and the complications are already there. So life expectancy, if they're young, have a long life expectancy, you're going to be more stringent. If they're elderly and have a shorter life expectancy, you're going to be a little less stringent. Established cardiac and other comorbidities, again, if they have, newly diagnosed, relatively healthy, you diagnose a 43-year-old, and they don't have a lot of other health problems, you're going to be more strict with them and push them a little bit more to hopefully prevent them from developing problems later on. If they've already got a lot of comorbidities or a lot of vascular complications, claudication, things like that. They've already lost some of the blood flow to their feet or things like that. Strict control is not going to help at that point. So you might be less strict. And then patient attitude, both these kind of go together. Patient attitude and expected treatment efforts, are they highly motivated? Do they, have good self-care capabilities where they're willing to check their blood sugar, they're willing to exercise, they're willing to follow a diet and really work at it? Or are they very non-compliant or non-adherent and don't have very good self-care capabilities? And a lot of this also goes hand in hand with resources. Do they have readily available resources to, join a gym, to eat healthy foods that sometimes cost a little bit more? Fresh fruits and vegetables cost more than French fries from McDonald's. Or are their resources limited? So you need to look at all of these things when you're trying to decide, where you're going to pick an A1C goal for everybody. Not everybody's going to be right here in the middle at 7. Some, elderly person with more complications might be 7.5, and some young person with very few that's very motivated might be 6.5. Okay, so the ADA recommendations, an A1C of less than 7 for most adults and less than 7.5 for children. You want to be careful about hypoglycemia in children, so they keep their A1C a little bit higher. A preprandial blood glucose of 80 to 130. A peak postprandial, that would be an hour to 2 hours after eating, blood glucose of less than 180. Blood pressure of less than 140 over 90 and less than 130 over 90 if possible without added treatment burden. This is about to change, I think, in the next guidelines that come out next January. They used to say 130 over 80. The ADA about maybe 3 years ago was still 130 over 80. Then JNC8 came out and they bumped it up to 140 over 90. So last year, the ADA kind of gave in and said, okay, to go along with everybody else, we'll say 140 over 90, but we really think it should be lower if it can be done without treatment burden. And treatment burden means, extra expense, extra medications, extra side effects, extra complications like postural hypotension, things like that. If you can get their blood pressure down without having them have a whole lot more symptoms, then it's worth it. So I think we will see this number coming back down now that the new guidelines, the American Heart and American College of Cardiology, they just came out in December. ADA publishes their guidelines in January, so they were, already finished probably. But I think next year we'll see that come down. I'm going to leave it at that for the exam, since that's what all your book says. Okay. Lipids, the use of statins, pretty easy to remember. If they're less than 40 years old, and this is for type 2 diabetics, less than 40 years old and have no cardiovascular risk factors, then they don't get a statin. You're not going to see too many of them. If they're less than 40 and they do have cardiovascular risk factors, they're high blood pressure, they are overweight, they are sedentary, they have early, family history of early heart disease, any of those things, high lipids, a smoker, then they're going to have moderate to high intensity. If they're 40 to 75 with risk factors, high intensity, all diabetics with overt cardiovascular disease, high intensity, and over 75 with cardiovascular disease, moderate to high intensity. And this should be all diabetics. I think I have an error on there. So basically, the only ones that aren't going to get a statin are those under 40 with no risk factors for heart disease. Everybody else is going to get a statin. That's bottom line, what you're going to remember. Okay, so for testing, it's pretty easy. Give them a statin. Okay, aspirin, 81 to 162, 1 to 2 baby aspirins. should be used for most diabetic men and women over 50 with at least one other risk factor for cardiovascular disease and no increased risk for bleeding. So they're not on, they don't have a bleeding disorder, von Willebrand's or something. So for testing purposes, we will assume that if they're over 50 and have risk factors, then they should get aspirin. They used to do their 10-year cardiovascular risk, probability of cardiovascular disease on the American Heart Association website. They don't do that anymore. So pretty much over 50, if they have hyperlipidemia, hypertension, obesity, smoking, any of those things, they're going to get aspirin. How do you decide between 81 and 162? I think probably just, how many risk factors they have, plus if they're, if they're a 130-pound female, I'd probably give the lower dose. If they're a 360-pound male, I'd give the higher dose. Okay. So statins for all. Okay. Treatment. Lifestyle recommendations. Exercise. Work up slowly to at least 30 minutes, 5 days a week. Alcohol. You want to limit alcohol to 2 drinks a day. And tell them, these are basically empty calories. They're, alcohol is full of carbohydrate, and there's really no other nutrients in there, and it increases their risk of hypoglycemia. If you have, 3 to 4 beers in the evening and then you go to bed, your liver is busy detoxifying, handling the alcohol and detoxifying that. What's your liver usually do at night? What's it usually make? Carry you through the night while you're not eating. Glycogen, okay? So your liver is, the factory for glycogen, which holds you through the night while you're fasting. So if your liver is busy metabolizing alcohol, it's not making glycogen, so you have increased risk of hypoglycemia, okay? Diet, low carb, low fat, calorie restricted for weight loss, Mediterranean diet, the South Beach diet, whatever diet they can stick with is the diet that will work for them. They've gotten away from the 2,000 calorie ADA diet and all the exchanges and everything like that now. Now they, basically say, eat a colorful plate, mostly fruits and vegetables and protein and decrease simple sugars and processed carbs. Okay, this is a little hard to see. I think I can, wait a minute. Didn't want to do it that much. Oh dear. Okay, I'm messing things up by doing that. Okay, if you guys can read it, I'll try to read it. Okay, so this is just the algorithm from the ADA that is in the ADA guidelines. At diagnosis on everybody, you want to initiate lifestyle management, set A1C goals, and initiate pharmacologic therapy based on their A1C. If their A1C is less than 9, which his is, you can consider monotherapy. If it's greater than 9, you should consider dual therapy to start. And if it's greater than 10, or equal to or greater than 10, or their blood glucose is over 300, or they're markedly symptomatic, like they come in, with a blood sugar, 500 or something, then you can consider combination injectable therapy like insulin. So he is at 8 point something, so he's under 9. So he's going to start with monotherapy. What's the first drug we start for everybody unless there's contraindications? Metformin, okay? So initiate metformin therapy if there's no contraindications. What are some of the contraindications for metformin? Chronic kidney disease. What creatinine? Okay. GFR of less than 30, but I believe that McPhee does it by creatinine, and it's Natalie's got it, greater than 1.4 in think it's in males and 1.4 in females, 1.5 in males. And that's what you should know for the exam. The ADA used to do it by creatinine, and this year they stopped and started doing it by GFR. But basically, they have an increased risk of lactic acidosis if they have chronic kidney disease and they are on metformin. But other than that, there's not very many problems with metformin. So let's move on. We'll come back to dual and triple therapy. Okay, so we're going to start him on metformin and then see him monitor his A1C in 3 to 6 months. So this is really hard to see, or hard to read, especially if you have terrible eyes like I do. You should be able to print this out from the ADA website and hopefully print it out in a larger format to be able to, print the slide. This is the only way I could do it. So basically, we're going to go through and talk about these medicines. There are a lot of, except for starting everybody on metformin at the beginning, all the other medicines are kind of potpourri. And you need to look at several different things about each medicine to decide which one to pick. And, students say, oh my goodness, it's so confusing. How do you know which one to pick? Well, it's not cookbook, and it's not, you give this one and then give that one. There are several different classes of medicines, and you have to consider different things for each patient. So you want to consider the efficacy, how effective it is, the risk for hypoglycemia. Again, if you have some, 78-year-old lady that lives by herself, you don't really want to give her something that's going to cause her to, get hypoglycemic and faint in the middle of the night. Weight changes. Does the medication help you lose weight or gain weight? What's the patient's weight? Is that going to be an issue? Cardiovascular effects. Some of them have benefits and some of them have risks for different heart things. So do they have risk factors for cardiovascular disease, or do they have actual cardiovascular disease like angina or things like that? Do they have congestive heart failure? There are certain medicines that are contraindicated in that. Cost, big issue. I know you've talked about it with Dr. Turnham about the cost of different blood pressure medicines and polypharmacy. So, some of these newer medications are very expensive, and they might not be able to afford them. So I think I've got this. I think we'll run off the side of the page here. I'm not seeing the list over here. Renal effects. Do they have any effects on the kidneys? And some of them have benefits, some of them have risk factors for kidneys, and then just some additional comments. So let's just go through the. I don't have. Can any of you see the red column over here? Hang on one second. Let me get my. Yes, you can. Okay. I assume that this first one is metformin or biguanide, where my pointer is. Am I correct? Yes. Okay. So the metformin is a biguanide. I do want you to know the class of the medications. It's really the only medication in that class, so it's pretty easy to remember. It's Glucophage is the brand name, but most people just go by metformin because it's free at Publix, $4 everywhere else. It's highly effective, brings the A1C down usually 1 to 2%, has a low risk for hypoglycemia. It's either neutral for weight or can cause some weight loss. It's not going to cause dramatic weight loss, but a lot of times people get a little bit of GI irritation or upset, so they don't eat as much. Plus, it just does help a little bit with weight loss. So it doesn't put the pounds on. Cardiovascular effects, there's potential benefit for if they have risk factors for cardiovascular disease, and it's neutral if they have CHF, so it's not going to aggravate CHF. It's very low cost, as we said, free or $4. It's taken orally. It is neutral as far as the kidneys. Oh, there they are. Oh, okay. Neutral as far as chronic kidney disease, but you do need to watch if they have GFR of less than 30 or that creatinine greater than 1.4 or 1.5. Main side effect is going to be GI distress, which usually goes away with time. So you want to start like 500 milligrams a day, and then over a week, try to go to 500 milligrams twice a day, with the eventual dose being 1,000 milligrams twice a day. Okay, the SGLT2 inhibitors. Okay, and I want to say the way the biguanidines work is they decrease the hepatic production of glucose, and they increase the tissues, peripheral tissues sensitivity to insulin. So a big problem in type 2 diabetes is insulin resistance. So they're making insulin on their own, but they're so resistant, their body is so resistant to the insulin that it's not effective. So metformin and the biguanides are insulin sensitizers. Maria asks, how often would you assess kidney function if no symptoms? Every 6 months to a year if they're not having any issues. Once you screen them at the beginning. I don't know if the sulfonylureas are on here. Okay, these are sulfonylureas down here. I have them on I have a little cheat sheet that has them in different order. Sulfonylureas have been around forever. They're very inexpensive. They are highly effective. Can drop the A1C pretty, 1 to 2 points. They do have risk for hypoglycemia because the mechanism of action is to stimulate the release of insulin from the patient's own pancreas. So that is independent of whether they're eating or not. So they take the medicine, they're going to have insulin release, and if they haven't eaten, their blood sugar is going to go down, so they can have hypoglycemia with this. They tend to make them gain weight, as any insulin will do. It's not an insulin, but it's stimulating your insulin. And remember, insulin's job, insulin is the key that unlocks the cell to let the sugar in. If the sugar can't get in the cells to be used for energy for the body, then it's just floating around in the blood. And so that's why you have high blood sugar. If it gets too high, it gets excreted by the kidneys and you have sugar in your urine. But sulfonylureas help the body to excrete its own insulin, and so you're going to use that sugar and you're going to gain weight. Okay. Potential benefit. Went to the wrong one. Neutral as far as cardiovascular benefit or risk. They're very low in cost. Again, those are probably $4. They're oral. They're neutral as far as kidney disease, and main side effects are going to be hypoglycemia. Okay. Let's go up to the SGLT2s are a new class, maybe 5 years old. So they have intermediate effectiveness. They'll bring your A1C down about 0.7 to 1. Not a whole lot, not as high as metformin, but they do work. They don't have increased risk for hypoglycemia. They do cause you to lose some weight, and the mechanism of action for the SGLT2 inhibitors is that they raise the threshold for reabsorption of glucose in the renal tubules. So you've got, blood glucose is high, and if you get to a certain point, and I don't have the numbers in front of me, but the renal tubule will filter out that glucose, and then it's reabsorbed as long as it's not too high. If it gets too high, then it's excreted in the urine, and that's why you have glucosuria, when you have diabetes. SGLT2s inhibitors, what they do is they lower that, they raise that threshold for reabsorption. So the glucose that's in the blood is filtered by the kidney, and instead of getting reabsorbed in that tubule and going back into the blood, that threshold is higher, so it has to be even higher. So the sugar is excreted in the urine. So this will give them glucosuria just because that's the mechanism of action. There is some benefit with Jardiance, which is empagliflozin, has a cardiovascular benefit and can decrease the incidence of heart attack and stroke. So it has a indication for that. And same thing for CHF. Their cost is very high. They are oral medications. And they do have benefit for the kidney too. They do have limits as far as if they have chronic kidney disease, and there are different contraindications based on their kidney function. So if their kidney function gets too low, they're not going to be able to use these. Okay? And as I said, this is causing them to excrete more of that sugar into the urine. Instead of having it reabsorbed into the blood and keeping their blood sugar high, it's getting filtered out by the kidney and doesn't get back into the blood. So now you have sugar in your urine. Think about what side effects that's going to cause. What are the main side effects with these drugs? Okay, infections, okay, UTIs, yeast infections, same thing you see in an uncontrolled diabetic. Sugar, bacteria love sugar. So, and then hypotension, because remember, sugar is osmotic. The kidneys work on osmotic pressure, and sugar is a molecule. So where that molecule goes, water goes. So they also lose some water when they lose that sugar, and they can get hypotension. So they have to make sure that they're drinking enough, that they don't get dehydrated and get low blood sugar. Okay, and they have to watch for yeast infections and mycotic infections. And hypertension maybe, yes, because of the loss of water. So they just need to make sure that they stay hydrated. Okay. So I hope I didn't confuse you. They inhibit SGLT2 in the proximal nephron, raising the threshold for glucose reabsorption, resulting in increased glucosuria. Okay. Which one's next? This one, I can't even see. Can somebody tell me what this one is? I can't see what that one is saying. Is that GLP-1s? Okay. So the GLP-1s, those are injectables. Those are the GLP-1 antagonists, Bydureon, all the tides, exenatide, liraglutide, dulaglutide, lixisenatide, all those, Trulicity, Victoza, Tanzium, Byetta, Bydureon. These are all medications that are injected anywhere from once a day to once a week. They are highly effective. They do not cause hypoglycemia because their mechanism of action is by the incretin. They stimulate the incretin effect, which is when you eat glucose, when you eat a carbohydrate that has glucose in it, and you have glucose in your gut, your pancreas, the incretins in your gut stimulates your pancreas to secrete insulin. So that's what these do. There's diabetic, when you're a diabetic, that incretin effect kind of gets dulled. So these stimulate that effect. So the incidence of hypoglycemia is less because the insulin is only stimulated if in response to glucose in their gut. So if they take this medicine and then don't eat breakfast, it's not going to cause them to secrete insulin until they get some carbohydrates in them. Unlike sulfonylureas, that you take that, it's going to start secreting insulin right away. There's a lot of information on this chart. Are there specifics we should really focus on for testing? As with all medications, and that's why I'm going over this, I want you to know the class and be able to recognize the drugs in that. And if you look at them, usually the endings, the metformin is the only biguanide. All the DTP4s, we're going to get to those. There's the gliptins, the SGLT2s, or the flozins, and the GLP-1s are the tides. So you just look at the ending and you can know what class they're in. So I want you to know the class of medication. I want you to know how it works. I want you to know, I'm not going to, you need to know the side effects So that's why we're going over, does it cause hypoglycemia? You need to know the contraindications. Is it, contraindicated if you have kidney disease? Like if you're metformin, if you're creatinine, sorry, I've worked all day today. If your creatinine is real high, you need to know that with metformin. And then just the basic side effects. So same thing we've been doing since the very beginning with medications, but if you learn them on a class base instead of, one by one, it's a lot easier because most of them have, all the GLP-1s have the same side effects. All the SGLT2s have the same side effects. And if you understand the mechanism of action, a lot of times those side effects make sense. You have a bunch of sugar in the urine from an SGLT2, you're going to get yeast infections and UTIs. GLP-1s, their mechanism of action is to increase the release of insulin in response to eating carbohydrates, so they don't cause hypoglycemia, because if you're not eating the carbohydrate, it's not going to stimulate it, and they slow down the transit in the GI tract. So what's going to be the big side effect? If everything slows down in the GI, bad GI, what side effect specifically? Nausea and vomiting, okay? You tell these patients, if you continue to eat, we tend to be a society on the go, and we go to McDonald's and we get a Whopper and we eat it in 5 minutes. You do that with a GLP-1 and you're going to be revisiting that Whopper in about 15 minutes. So, if you understand the mechanism of action, a lot of times you'll understand the side effects. Another effect of the GLP-1s is weight loss, because they slow transit through the GI tract. Patients feel full for longer. They tend to eat less. And I think there's also a centrally acting component on the brain that causes increased satiety, so they're not eating as much. So these are good for weight loss. So weight change is weight loss. They are neutral as far as most of them are neutral as far as cardiovascular benefit, except for Victoza, which is liraglutide, and that has proven that cardiovascular benefits. So that one is indicated. Neutral as far as congestive heart failure. They are high in cost and they're sub-Q injections. And then there are some, with all medications, there are going to be some instances with chronic kidney disease that you have to watch for those. And you need to look at the contraindications if they have gastroparesis, where their bowel isn't working well anyway, and it's kind of everything's going through real slow anyway. You don't want to give them a GLP-1 and add to that. If they have certain types of cancers that run in their family, then you need to watch out. And these can cause pancreatitis, so you want to watch out for that. Okay, we talked about the SGLT2 inhibitors. We talked about sulfonylureas. Yes, sulfonylureas. These are, TZDs over here. I can barely see this red column. TZDs, there are only two. It's pioglitazone, which is Actos, and rosiglitazone, which is Avandia. They are both highly effective. They do not cause hypoglycemia. They usually cause you to gain weight, mainly through fluid retention. The way they act is also kind of like metformin, in that they are insulin sensitizers, and so they help the body to use insulin more, and that's going to make you increase in weight. There is a potential benefit for cardiovascular risk factors for pioglitazone, but there is increased risk if they have CHF. So if they have American Heart Association class 3 or greater CHF, then Actos or pioglitazone is contraindicated. They are low in cost now. They're oral. They're okay with kidney disease. And they have very few side effects except for edema and weight gain. So a lot of times they'll have swelling in their legs and feet and weight gain. And some of that weight gain is due to the fluid. We talked about the sulfonylureas, and insulin we're going to talk about in a little bit. So we won't go on that. Okay. So I tried to go over most of the ones that we're going to see. Oh, the only other one we didn't, did we go over DDP4s? I guess so. Those are, DDP4s are up here somewhere. I can't even see on that. DDP4s are the like sitagliptin, which is Januvia, or saxagliptin, which is Onglyza, Tradjenta, which is linagliptin, and those also increase the incretin effect, kind of like the GLP-1s, but these are oral. They're not quite as effective. They don't have, it's the fourth one down, here they are, intermediate in effectiveness. They don't, I hardly ever use them because, I mean, you get like, 0.5 decrease in A1C. You just don't get that much. They are neutral for weight. They don't cause hypoglycemia, neutral for cardiovascular benefit, potential risk if they have heart failure. They do cost a lot. That's another reason I didn't use them. Kind of neutral for the kidneys. So you don't see these used quite as much anymore. And then there are a lot of combination medicines that, combine metformin with, one of the other medicines or things like that. And I'm not going to test you on any of those combinations. Okay. What am I doing? Okay. There are some new combinations that I put in the announcements, and I'm not going to have them on the test because they're pretty new. And they are combined GLP-1 and insulin, basal insulin preparations. Soliqua, I guess you'd call it, which is Lantus and lexosenatide, and then Zoltofri, which is Tresiba and Victoza. But I'm not going to test you on those. But those are both injectable combinations that you can use that combine a basal insulin and a GLP-1. Okay, so now let's get back to Mr. Stewart. Let's see, let me look over here and see what people are saying. Lydia says her preceptor says GLP-1s are absolutely the next go-to after metformin. Is it just her preference, or GLP-1s what most providers would prescribe after metformin? I think GLP-1s now are way up there in the treatment protocol. A lot of it is, can the patient afford it, because they're expensive? So they have, health insurance, or are they eligible to get, patient assistance? And are they willing to take an injection? So those are the two things. Some people absolutely will not take an injection. So, GLP-1s are going to be out for them. But, you look at it and, if you want to keep them on the metformin, because that sensitizes the body to insulin. And the GLP-1s are going to make insulin, so you want them to be able to use it. But the GLP-1s help with weight loss. I mean, and most of these patients are overweight. They have cardiovascular benefits, and most of these patients have cardiovascular risk factors. You very rarely see diabetes just by itself. It's usually, obesity, hypertension, diabetes, dyslipidemia. So, they have benefits to that. They are highly effective in bringing down the A1C, and some of them are only once a week. So I think, if the patient can afford a GLP-1 and they need to lose weight and they're willing to take an injection, then I think GLP-1s are a good alternative. I think we're getting away from the older drugs like sulfonylureas and things like that have side effects like hypoglycemia when we have these newer medicines. Okay, so medications. For hyperglycemia, what are we going to give Mr. Stewart? This is still his first visit. We're going to start him on metformin. Again, we talked about starting at 500 BID and titrating up to 1,000 BID. Usually you can do that over about a 2-week period. Tell them to take it with food. It helps with the GI upset. For his hypertension, an ACE such as lisinopril. I know in your hypertension unit, you probably talked about using this class for African Americans, this class for, Caucasians and different things like that. The ADA recommends an ACE inhibitor for hypertension, for renal, correct, Maria, for renal protection in anybody that has microalbuminuria, and he did. His albumin creatinine ratio was 65, and 30 is the cutoff. So he's already having a little bit of kidney effect. So let's get him, since he needs antihypertension medicine, why not use one that's going to protect his kidneys? So lisinopril or any of the other ACEs. If you can't tolerate an ACE, you can try an ARB. Dyslipidemia, he's going to get a statin like atorvastatin or Lipitor, start at 40, and you can titrate up to 80 as needed. His hypothyroidism, we talked about this last week. Start levothyroxine. You want to start low and go slow, start anywhere from 25 to 50 micrograms a day, and titrate up until you get his TSH down to under 2.0. Usually do that every 4 to 6 weeks by checking the TSH. And then aspirin, 81 milligrams a day for primary prevention of cardiovascular disease, since he has, dyslipidemia and obesity and sedentary lifestyle and hypertension. He does have risk factors, and his father died early of cardiac disease. So all of those are risk factors. Okay, any questions on the medicines that we're going to start him on this first time? And this is based on a real patient, and he came in on no medicines, not being to a provider in 8 years, and he went out on 5. He was a little overwhelmed, but yes, he did improve. Let's look. Okay, what vaccines does he need? He hasn't had any vaccines in 30 years since he was in the military. What does he need? Okay, he needs a tetanus or DTaP, not just tetanus. Okay, and he needs pneumococcal. Okay. I wrote a question above about starting all at once. Yes, you could start all of those medicines at once. Let's see, Brittany said, are we going with metformin dose of 1 to 2.5 grams divided BID or TID, or 5 to 2,000? You can go up to 2.5 grams of metformin a day. I rarely see anybody go up over 1,000 milligrams BID, which is 2 grams a day. You just don't get that much more effect from it. So I usually just go 1,000 milligrams BID. Start slow at 500 and gradually build up over 2 to 3 weeks to get to 1,000 BID. Would you start all these medicines at once? I didn't see where that question was, but I feel like starting all these drugs at once would be confusing, hard to determine what drug is causing which, and overwhelming. You could stagger a little bit, but which one are you going to stagger? He needs to get his blood sugar under control, so you need the metformin. His main symptom today was fatigue, and he has hypothyroidism, so he's not going to really feel better until he gets his thyroid situated. Blood pressure, we're starting on a low dose of blood pressure medicine. That is important both for his kidneys and to get his blood pressure down. And lipids, again, if you had to stagger anything, I would maybe start the lipid medicine in a couple weeks. But I would, I probably spent 2 hours with this patient when I first saw him, and try to explain why he needs these different medicines. Most of these medications are once a day, so he can take all of them together except for the metformin, which is twice a day, but his blood pressure medicine, his Zocor, his thyroid medicine, and aspirin are all just once a day. So most of those don't have that many side effects. So he was able to take all of them and start all of them, and all of those medications were either free or $4. So it wasn't a whole, a lot of money for him to start right away. But he does need a lot of support. If you have a patient like this, you want to, if they have a family member there, a wife or a husband, you can talk to them and tell them why you're doing this and what each medicine is for, what side effects are, and what to watch for. But after not having care for 8 years, he's probably had some of these problems for a while. So it was kind of, a lot to fix in one day. But yes, you could, start him on his metformin and blood pressure medicine, have him come back the next week and start him on his Lipitor and his levothyroxine or something if he was, if you felt that he was just totally overwhelmed and couldn't handle it. That is a good point. You have to know your patient. He was okay with this. So, okay, so we're going to give him flu vaccine if it's still flu season, pneumococcal PPSV 23, a DTaP, and you could recommend a hepatitis B series since he probably hasn't had that. And then Mariah says if you fix his thyroid, maybe he'll work on lifestyle. Yeah, if he's got severe fatigue, he's probably not going to want to work out. Keep messing up my screen. What am I doing? That's totally messed up my screen. Okay. So when would you want to follow up with him? What labs would you recheck? And what referrals would you do? Okay. So 4 to 6 weeks for the thyroid, 3 months for everything else. Thyroid, 6 weeks. My screen has messed up and I'm having a hard time seeing your comments now. Okay, so 3 months for the A1C. TSH you're going to do in 4 to 6 weeks to titrate his levothyroxine. Let's see, refer for dental and eye exam. He needs a dilated eye exam and he needs to see a dentist. Refer to an endocrinologist. He really, his A1C is not that high. He probably doesn't, this is a primary care patient. He can be handled by a nurse practitioner. You probably don't have to refer to an endocrinologist. And in some areas like here, we have very few endocrinologists and it will take forever for him to get in. So he, at least for now, could be handled by primary care. Let's see, refer to a dietitian and diabetic educator. Excellent. Yes, he is going to need diabetic education, whether you have a community center, whether you have a dietitian or a diabetic nurse educator that works in a clinic. He's definitely going to need help learning about diet and exercise and his medications. Dentist, okay, recheck, and ophthalmology. Okay, and Maria says he needs a colonoscopy. Yes, that's another referral. Think health promotion. He does need a colonoscopy. And would you refer to cardio at this point? At this point, he's not saying that he has any chest pain or angina or anything like that, so he probably would not be, I would do a baseline EKG, but he probably doesn't need to be referred to cardiology at this point. Okay, and decreased pulses, his pulses were a little bit decreased in the lower extremities. That's not that unusual in patients his age. So unless he had, unless you really thought he had arterial insufficiency or anything, you probably wouldn't need a cardiologist at this time. So follow up and referrals. Let's repeat his TSH in 3 T4 in 6 weeks, and then titrate his levothyroxine. Repeat CMP, lipids, and A1C in 3 months. Follow-up visit in 3 months or sooner if he's having any problems such as medication intolerance. Refer for diabetic education. Refer to an ophthalmologist for a dilated eye exam, and refer to a dentist every 6 months, which is really important. Dental hygiene is very important in diabetics because they tend to have more problems with their teeth. So 3 month follow-up, Mr. Stork came back. His current medicines, he's on 1,000 metformin BID now, tolerating that okay. His lisinopril is 20 milligrams a day. His atorvastatin is 40. He's on the low-dose aspirin, and levothyroxine has been bumped up to 75 micrograms. He's attended 3 diabetic education classes. He's walking a mile a day, 3 days a week, and his weight is down to 200. He's trying to eat better with less carbs. He had a dilated eye exam and didn't have any evidence of diabetic retinopathy. And he had a dental exam and had 2 caries repaired. So his BP is now 134/80. Is he at goal? Yes. Okay. His labs at 6 weeks, his TSH and free T4 were 3.2 and 9, so it's still a little bit high. So we bumped him up, his levothyroxine up to 75 micrograms at that time. Today, his lipid panel, total cholesterol has come down to 190, LDL is 120, HDL is 49, triglycerides are 160. We on target with these lipids? Okay, no, those are still kind of high. Fasting blood sugar is 154, and A1C is 7.9. Creatinine is staying at 1.1. Do we still need to work on his blood sugar and A1C? It is better, but yeah, we need to work on it. And his TSH now is 3.1 and 1.1 free T4. Do we need to work on his thyroid? Yes, it's still a little bit high. And his urine albumin creatinine ratio, which you probably would only do once a year for some reason I stuck that in here again, has come down, but you do want to continue his lisinopril because it's obviously doing its job. His exam is unchanged. So we said he's not meeting some of his goals. He is meeting his blood pressure goal, but he's not meeting his goals for his blood sugar, his lipids, or his thyroid. So we're going to need to make some treatment adjustments. Let's see. So I have a touch screen, and I don't know what I'm doing here. I keep messing it up. There you go. Okay, I'm not going to touch anything now. I'm not used to the touch screen. So we look back at this algorithm again. We started him on monotherapy with metformin at the beginning and lifestyle management. At 3 months, we monitor his A1C, and it's still elevated. So he needs to have something more added. So we're going to go to dual therapy. We can add an agent if he has cardiovascular disease, active cardiovascular disease. We can add an agent that reduces that, like Jardiance or Victoza. He doesn't have active cardiovascular disease right now. He has risk factors, but not active cardiovascular disease. So you can add a different agent from another class of drugs, just again, based on patient factors and drug side effects that we talked about before. So we could add, give me some recommendations. What could you add? Remember, he does not have any insurance. We could add a GLP-1 if he could afford it. Okay. We could add a sulfonylurea. It's very inexpensive. We could add, okay, Brooks has a fast-acting insulin. Probably wouldn't want to do that just yet because he's not even, he's only on one oral medicine. Brittany says NPH. Probably would not start him on insulin just yet because his A1C is coming down at 7.9. So he doesn't need to come down that much more. Okay, so, and wouldn't sulfonylureas cause weight gain? Yes, they can cause weight gain. So there are all those classes, SGLT2s, the GLPs, the DDP4s, the sulfonylureas. We can choose from any of those that he can tolerate and that he can afford. So let's add a second agent to control his hyperglycemia. His blood pressure is well controlled at this time. His statin needs to be increased to reduce his LDL. We want to get it under 100. So increase his Lipitor to 60. His TSH and free T4, his TSH is still high and his free T4 is still low. So we want to increase his levothyroxine to 100 micrograms a day. And that's not, an unusual dose for somebody his size. You want to recheck his TSH in 6 weeks and have him return in 3 months for another CMP, lipid, and A1C. Okay, someone said, I thought we want LDL under 70 in diabetes. Under 100 for everybody, under 70 if they have cardiovascular risk factors, which he does, and if you can get it that low. It's really hard to get it that low, but that is kind of a goal to try to, get it, the LDL as low as you can, the HDL as high as you can. Increase exercise or frequency to help with weight gain, with weight and HDL. Those are both good recommendations. Okay, so Mr. Stork gets lost. 18 months later, he shows up at the clinic again, and he's been lost to follow-up for several months due to a temporary move out of state. He did continue his previous meds, although he admits that he occasionally ran out of medication for a few weeks at a time. He states he's still trying to eat a low-carb, low-fat diet and has cut out Coke. He's walking 2 to 3 times a week. He recently found a job and is now covered by health insurance. So, yay! He is now complaining of occasional burning pain in his feet, and he was recently diagnosed with angina. Okay, so that changes him from risk factors to active arteriosclerotic coronary vascular disease. Okay, his current medications, he is on metformin, 1,000 BID, and he was started on glipizide, 10 milligrams a day out of state. So he's on his sulfonylurea. He's still on his lisinopril and his aspirin and his Lipitor of 60 a day, but he often goes without that. His levothyroxine is still 100 mics a day. Today, his weight is back up. He's 215 again. His BMI is up. His blood pressure, look okay, 136/78. So his blood pressure is still good, so that lisinopril is still working. On his exam, his feet have some decrease in sensation to monofilament. His labs, his total cholesterol is 189, so it's still up there. LDL is still above 100, 105. And now that he has angina, you do want his LDL to be down as low as you can, under 70. HDL is coming up a little bit, but still not as high as you'd like to see it, and his triglycerides are still over 150. Fasting blood sugar, 240, A1C 9.8, so he's going in the wrong direction. And his TSH and free T4, how are those doing? And his TSH and free T4 look good, so 1.1, so his TSH is under 2, so his levothyroxine dose is okay. So we've got to work on cholesterol and we've got to work on his blood sugar, okay? What kind of complications is he starting to have? Neuropathy, okay? Yeah. How often do you want to do a foot exam on diabetics? Every visit, okay? All diabetics take their shoes and socks off. You do a foot exam at every visit. Okay, remember, as they get neuropathy, they can't feel if they've got a problem on the bottom of their feet. And, I'm not overweight at all, and I run and I'm pretty active, but I'm 61 and I have a hard time getting, my foot turned up and looking on every aspect of my feet just from arthritis. So you can imagine if you have somebody that is, over 200 pounds, they can't see the bottom of their feet. So you need to look at their feet. Brooke asked, do you need to do a monofilament at every visit? Technically, no, but you do need to do a visual foot exam at every visit, and you'd be amazed at how many preceptors don't do that and how many preceptors don't do a monofilament. So it's not going to take you any more time to use a monofilament on a foot when you're looking at them. So I did it when I worked at the health department. We did it at every visit. Okay, so we've talked about what goals he's not meeting. He is meeting his blood pressure and his thyroid goals, not meeting his A1C or his cholesterol goals. So how would you adjust his therapy today? What are some options that you could go with for him? Okay, somebody said add Victoza, increase statin, yes, add insulin, maybe add Victoza again for cardiovascular benefits, take him off sulfonylureas and add Victoza. Discuss compliance with the statin, that's important. Find out if it's causing him to have muscle aches or if he just can't afford it. Okay, so all those, add basal insulin. Those are all good suggestions. So he is now down to triple therapy. He's been on metformin, lifestyle, and an additional agent, which is glipizide. And now, his A1C is almost up to 10, so he needs to have 2 other agents. He does now have now have active arteriosclerotic coronary vascular disease because he has angina. So you would want to consider something that's going to protect his heart. Okay, so BP is at goal on his lisinopril. Statin, you could increase to 80 milligrams a day, which is high intensity, to try to get his lipids down. You want to continue his aspirin for cardiovascular protection. Choices of diabetic med, you can add a 3rd agent from a different class. You could replace the glipizide with empagliflozin, which is Jardiance, or liraglutide, which is Victoza. Both of those address both of those have the cardiovascular benefit of decreasing incidence of cardiovascular events. So those would be good choices for him. You could add basal insulin. You could add one of the new combination medicines that I just told you about, that like the Tresiba with Victoza, which is the Zoltofi, or the Lantus with exenatide, which is Zolquai. So you could do two birds with one stone on that one. But I think with his weight increasing, he either needs to have a trial of a GLP-1 like Victoza, or go on Jardiance. And if he just goes on Jardiance, I would try basal insulin. But all of the GLP-1s can be used with basal insulin, so you can do both of them together. And then you want to add a medication for his diabetic neuropathy, such as pregabalin or duloxetine. Those help with the burning pain that they have with diabetic neuropathy. Let's see, how do you know which class is best to add with metformin? Like we talked, that big confusing slide at the beginning where I went over all the different classes, you want to consider those things. First, now he has health insurance, so can he afford it? Most likely. That gives you more options. Before, he didn't have health insurance, so going with a sulfonylurea like glipizide was a choice for him because he could get it for $4. Most of the other SGLT2s and GLP-1s he wouldn't have been able to afford. So now that he has health insurance, and he also has active cardiovascular disease, you want to consider that. You want to look at one of the medications that has a proven benefit, such as empagliflozin or liraglutide. His weight is back up, so you want to look at medications that won't increase weight gain too much. Any insulin, even basal insulin, will have some increase in weight, but at this point, with his A1C as high as it is, he's going to need something. So I would probably start with either the empagliflozin or liraglutide, and then within 2 or 3 weeks, if things aren't coming down, go ahead and add a low dose of basal insulin. Okay. He needs to visit the dietitian again. Yes, he probably is still, diabetic education shouldn't be, one time at the beginning of at the diagnosis and then never again. They can always go back and talk about, okay, what are we doing now? What's working? What's not working? Where does he still need help? So more dietitian or diabetic educator. And especially if he's going to go on insulin, he'll definitely need to see a diabetic educator. Remind him of the best way to tackle his diet. That's good. Recommendation. So any questions before we go on to talk a little about insulin? Any questions on the case study and on what you would do with him? I wish you could just say, well, you give him metformin, then you give this one, then you give that one, but it isn't like that. It used to be a little more of an algorithm before they had all these classes of medications, like maybe 10 years ago. But SGLT1s, the SGLT2s, the GLP1s, DDP4s, all of these have come about in like the last 15 years. So there are so many more medications now, and you just really have to look at the patient and decide, based on, their cost, their side effects, their other comorbidities, their willingness to take injections, their weight, all those things, their cardiovascular problems, which one would be best for them. And that's why it's so important to know, all those indications and contraindications in the medication, because otherwise you're not going to know which medication to pick. Okay. Any questions about the case study? I totally confused you now. So statin for everybody, aspirin if they're over 50 and have any cardiovascular risk factors, ACE if they have, or ARB if they have high blood pressure. Always check their thyroid, because that's common to have hypothyroidism and diabetes together. Okay, and then all the diabetes meds. Okay, so I gave there's a PowerPoint in there, a narrated PowerPoint on insulin usage and calculating insulin dose based on advanced carb counting and basal bolus. And I've had a lot of students that get confused by that, and they asked me to please explain some of that. So I added some slides to this presentation a couple years ago. So I'm going to go through those real quick. There are all kinds of different regimes for taking insulin, and most type 2 diabetics are going to start out with, 1 injection a day of basal insulin, and there's not a whole lot of calculation to that. Usually start at 10 units and go up. Then if they continue to have high blood sugar, you can add fast-acting insulin at their largest meal. Or you can go to like a twice-a-day NPH. If they continue to have elevated blood sugars, you can go to fast-acting insulin, plus basal, fast-acting insulin at each meal, plus their basal insulin. Once they get to that, you'll see a lot of older preceptors still using sliding scales. If any of you work in the hospital, you know that most of the time they don't use a sliding scale, or they shouldn't use a sliding scale. Sliding scale is kind of a backwards way of calculating your insulin dose, because you're checking your blood sugar and saying, okay, how high is my blood sugar? And you're treating what your blood sugar is from what you previously ate, not what you're getting ready to eat. So you're always chasing your tail, treating the high blood sugar and then not taking into account what's coming up. So a more physiologic approach to insulin dosing, and this is used by most type 1 diabetics who take multiple injections a day, is called basal bolus method, and it uses advanced carb counting. And so this is a more complex but most physiologic regime. It's usually reserved for type 1 diabetics, but an educated type 2 diabetic that's motivated can use this method. If they need multiple injections a day, then this is the best method for them. It's similar to how insulin is dosed for an insulin pump, but it's given as multiple injections as part of the basal bolus regime. And it takes into account both the patient's current pre-meal blood glucose and what they're getting ready to eat for their upcoming meal. So it's treating both any high blood sugar that they already have plus what they're getting ready to eat. Okay, so patient selection, it's typically going to be most type 1 diabetics, should be managed this way. Patient must be able to read food labels or to refer to a book or an app on their phone, such as Calorie King, that lists the calorie content and the carb content of foods. You can get all kinds of apps on your phone, much more popular in the last few years with South Beach and all the low-carb diets. You can go on and find every carb count for every restaurant and pretty much every food. They have to be able to monitor their blood glucose before each meal and interpret the results, and they have to have some basic math skills to be able to calculate. So patient education is really the key with this. Okay, so not every You're probably not going to teach too many patients how to do this, but I do want you to learn it. It's not hard at all. And you probably will see this on the test, so I'm going to go over it. But again, remember that there are all those other regimes that you don't have to do all the math for. So, but if they are going to be on basal bolus regime with advanced carb counting, the basal insulin dose is calculated like it is in any other regime, starting low and titrating until the fasting blood sugar is within the desired range. And Jennifer says her preceptor taught the last patient how to do this today. That's great. Okay. The bolus part is your mealtime insulin. So you've got your basal insulin that just kind of keeps you steady state. That's Lantus or Levemir or Tresiba or any one of those. Then your bolus insulin is going to be your mealtime insulin. That's a rapid acting insulin. And it's calculated for each meal by using two things, an insulin to carb ratio and a correction factor. And sometimes this is called a sensitivity factor. Okay, so calculating the insulin carb ratio. If you see this on the test, I will give you the insulin carb ratio, so you don't have to figure out how to do that. Most patients, the diabetic educator will do a long formula of how to do this, but most patients will start with an insulin to carb ratio of 1 to 15. And that means they will take 1 unit of fast-acting or prandial insulin for each 15 grams of carbs that they're going to get ready to eat. If they are very insulin resistant, like they're very obese, then they may need a little bit more, so they might have a ratio of like 1 to 10. Okay. For an example, the patient uses an insulin to carb ratio of 1 to 15, and they're planning to have 60 grams of carbs at lunch. So they need 1 unit of insulin for every 15 carbs. So they're going to need 4 units of insulin to cover that insulin to carb ratio. That's covering what they're getting ready to eat. Now, correction factor. Remember, they come into this meal and they might have high blood sugar at that, when they get ready to eat this meal. So you can't ignore that. You've taken care of what they're getting ready to eat, but you got to take care of any elevated blood glucose that they already have. So the correction factor is you're going to correct that high blood sugar. It's how much 1 unit of insulin will lower a patient's blood glucose. And you need to calculate this only once, and the diabetic educator will do this for you, so I'm not going to make you go through this. And then the patient uses this to determine its insulin dose. It's done by dividing 1,700 by total daily dose of insulin. I'm not going to ask you that on a test. You don't need to calculate it. I will give you the correction factor, okay? So don't worry about that. So an example is the patient's total daily dose with 60 units, his mealtime insulin plus his basal, he ends up with a correction factor of 28. So what that means is 1 unit of insulin should bring his blood sugar down about 28 milligrams per deciliter. I will give you both the insulin carb ratio and the correction factor, okay? So you don't have to calculate either of those. So where does the 1,700 come from? I don't know exactly. It's, a formula of, I don't know where I'm not going to guess, but I just know that's how you do it. You take their total daily dose and divide it into 1,700. So I don't know where the 1,700 came from. But, you can look it up. It would mainly be done by the diabetic educator, and they would help determine the dose. Okay, so let's just go through the calculation, and this is how you would do it. So you've calculated your patient's insulin to carb ratio is 1 to 15, and that's basically based on their body habitus and how insulin resistant you think they are. If they've been on all these medications and they don't have a whole lot of effect, and they're real obese, then you figure they're probably a little more insulin resistant. But for most people, you start at 1 to 15. So you've calculated this patient or decided that their insulin carb ratio is 1 to 15 and that their correction factor is 40. Their pre-meal glucose goal is 100, because remember, you want it to be 80 to 130. So we're going to tell that person, we want your pre-meal goal to be 100. So the patient is going to go to a dinner tonight that contains 75 grams of carbs because it's his birthday, so he's going to have some cake. His pre-meal blood glucose is 140, so it's 40 above his goal. He will need 75, he's going to eat 75 grams of carbs. He already knows what he's going to order. And you divide that by his correction factor, 15 up here, 1 per 15. So 75 divided by 15 is 5 units. So that he needs 5 units of insulin just to cover the meal that he's getting ready to have. Now he already is coming into the meal with an elevated blood sugar, so he needs 1 unit of insulin to bring his blood glucose down to goal because it was 140 and it should be 100, so he was 40 over goal, and his correction factor was 1 unit per 40. So before he eats dinner, he's going to take 5 units for his carbs, 1 unit for his correction factor, a total of 6 units of insulin. Okay, so let's do another example. So Miss Jones, her pre-meal glucose goal is 100, her insulin to carb ratio is 1 to 15, and her correction factor is 50. So Miss Jones checks her blood sugar before she eats lunch, and it's 200. So how far off is she? How far off of her goal is she? She's 100 off of her goal, okay? Her lunch is going to contain 45 grams of carbs, okay? So Brooke says for her correction factor, she's 100 over her goal. She's going to need how many units? Brooke says it, 2, okay? 2 units, because her correction factor is 50. 50 will bring her down, 1 unit will bring her down 50 points. So she's going to take 2 units of insulin to bring her blood sugar down to goal. And then how many is she going to need for her meal? 45 grams divided by 15, she's going to need 3. So altogether, how many units of insulin does she need? 5 units of insulin, okay? Any questions on the test will look like that. You'll have the pre-meal glucose goal, you'll have the insulin carb ratio, and the correction factor. So you will not need a calculator. These are simple things to do in your head, okay? I apologize if someone has asked, but why is the correction factor different? Is it based on the medicines or the weight? It's just, it depends again on their insulin sensitivity, how much 1 unit of insulin will bring down their blood sugar. If they're highly insulin resistant, then it might be that 1 unit of insulin only brings down their blood sugar 20 or 30. But so it's kind of a trial and error. You can see, if you're getting ready to start this, you could tell them, okay, take 1 unit of insulin and check your blood sugar in an hour. See how much it brings it down, so that you know about how much it brings it down. Okay, can we go over the correction factor one more time? Okay, correction factor is how much insulin they need to bring their pre-meal glucose down to goal. We give them a goal. We say, okay, we want your glucose to be between 80 and 130. That's the ADA guidelines for pre-meal, fasting glucose. So tell them to, pick a number in there. You don't want it to be too low. You don't want them to get hypoglycemic. So maybe 100. And then figure out their correction factor based on, their insulin sensitivity, or you can give them, have them try 1 unit of insulin and see how much their blood sugar goes down. So you've determined their insulin, their correction factor, and this is how much 1 unit of insulin should bring their blood glucose down. You have them check their blood sugar before their meal, see how far above goal they are. If her goal is 100 and her blood glucose was 250, then she's 150 above goal, and her correction factor is 50. That means 1 unit of insulin will bring it down 50 points. So she needs to come down 150 points. So how many is she going to need? She would need 3, okay? Does that help you with the correction factor? And then the insulin carb ratio is just, dividing what amount of carbs they are getting ready to eat by the carb ratio. Okay. So we will know this immediately with our patients then. Okay, Leo, I'm not sure what you're asking in regards to sensitivity. Well, I mean the correction factor? Are you asking okay, correction factor. You might not know it right away, but you can, like I said, you can test them. You can have them take, 1 or 2 units of rapid acting insulin, check their blood sugar, take the insulin. If their blood sugar was 200 and they take 2 units of insulin and it comes down to 100, then you know that a unit of insulin brings it down about 50. Okay? So it's going to take some trial and error. Okay? And then the insulin to carb ratio usually doesn't change. That's just, usually it's 10 or 15. And you just kind of do that by trial and error. If they are kind of an average patient, 1 to 15, if they're very obese or very insensitive to insulin, like they haven't been reacting, haven't had a lot of success with medications, then you might want to go 1 to 10. Okay. Let's see if there's, so on this one, the insulin carb ratio, she was going to eat 45 grams of carbs. 15 was her insulin to carb ratio, so she needs 3 units to cover her carbs. Her correction factor, blood sugar was 200, her goal was 100, so she was 100 over, and her correction factor was 50, so she would need 2 units to bring down her bring down her blood sugar to goal, and so her total dose would be 5 units. That makes sense? Okay. So any questions on anything we've done tonight? So you will see, are you seeing a lot of diabetics in your family practice? We usually haven't had people in family practice in the spring, so I always forget to ask. Okay, yes, yes, yes. I mean, diabetes is so common, and you're seeing more diabetes in peds. That's unusual. In adolescents or in overweight, type 2 diabetes in overweight peds. And Midori says she hasn't seen a new one. So we either have the option of doing basal bolus or doing sliding scale with bolus or bolus with correction. You have the option of doing, as far as the different insulin regimes, you can look back at my PowerPoint on insulin. There are a lot of things usually with type 1 diabetics, they're all going to be on this. They're all going to be on the basal bolus with carb correction factor and carb counting, because they have to have a very strict, they're not making any insulin on their own, so they have to have a very strict regime. With type 2 diabetes, once they're on insulin, you're usually going to start with a basal insulin. And now they're saying you can start the basal insulin with the the 2 new drugs, the Soliqua and the Zoltofi. You can start one of those, the GLP-1 with the basal insulin. But usually it's going to be 1 injection a day of the basal insulin. As time goes on, in type 2 diabetes, they're still making some insulin on their own, but their body's resistant to it. Over time, by the time most type 2 diabetics are diagnosed, they've lost 50% of the beta cells in their pancreas. So over time, their insulin production is going to go down. And insulin use should be seen as just a step in the progression of diabetes, not as a failure. Because over time, their pancreas is just going to kind of give out, and they may need insulin. But the regimes usually start as basal insulin. Then you may have to, if that doesn't control them, then you can add, you can either go to twice a day NPH, which not very many people do, only if they're it's less expensive, and there's no calculating. But twice a day MPH is not a very good regime because it doesn't take into account differing schedules and differing meals. If you're taking the same amount of insulin every time, you have to be pretty consistent about what you're eating. Most common after basal insulin would be basal insulin with rapid acting at the largest meal to help with that. And then you go on from there and, at the two largest meals. And finally, you get to every meal. And if you're going to have insulin at every meal, if you're going to have a shot of insulin at breakfast, lunch, dinner, and then basal insulin at night, then you might as well calculate it the correct way, instead of doing a sliding scale. Because like I said, if you're going to give yourself 4 shots a day, why not do it right? If you're doing a sliding scale, all you're looking at is basically the correction factor. All you're looking at is taking care of what you already ate, not what you're getting ready to eat. Okay. Let's see. Worried about remembering all the side effects from the different medicines and knowing when and what to add. Look at the classes of medications, look at the major side effects, contraindications, kind of know how they work. And then as far as knowing which one to pick, that is where your preceptor comes in. Know what your options are and ask your preceptor, okay, why are you choosing this one or that one? Offer a suggestion. Say, I'm thinking he's been on metformin for 9 months and his A1C still isn't at goal. How about a GLP-1 because he's overweight? Things like that. You can suggest things, but talking with your preceptor and gaining from their experience is going to help you understand why they're choosing one medication over another. And, it is complicated. You have to look at all those factors, the cost, the side effects, the cardiovascular effects, things like that. Brittany says she saw acanthosis in a 9-year-old today. And Tina says her preceptor has a lot of type 1 children with type 1 diabetes. That's unusual. And most type 1 diabetic children go to a pediatric endocrinologist. But, if you live in a rural area, primary care may be managing them. So you'll probably see a lot of, most of these kids are going to be using insulin carb ratio and correction factor and getting basal bolus insulin or using a pump. And this is the same thing they do in a pump. When you have a pump, you have to program it for your basal insulin, and then before each meal, you have to tell it how much you're getting ready to eat and check your blood sugar and give yourself that bolus of insulin. Let's see. On the test, we name the drugs. I believe that I have the generic names on the test. Okay. Tina says they don't have a pediatric endocrinologist, so that's reason you get to take care of pediatric type 1 diabetics. That's a good experience, though. Okay. Any other questions? This is probably one of the most complicated units you're going to have. So, you got to do it at some time, and you're going to see so much of this. So, it will, by next fall, you'll be going, oh, yeah, I'm going to give him metformin and GLP-1 and this, and because you will see it again and again and again, especially in the summer when you do internal medicine. About, a third or 50% of your patients will have diabetes. So it is, and people ask, what systems does diabetes affect? And it's like, well, anywhere that blood goes. If blood goes there, it affects your eyes, the blood vessels of your eyes, and causes retinopathy. It affects your kidneys and causes nephropathy. It affects the nerves and the blood vessels in your extremities and causes neuropathy and peripheral vascular disease. It affects the GI tract. It affects all kinds of things. So if blood goes there, then high blood sugar is going to affect it. So that's why, this is one of those diseases where you have to put everything together. I said you need to know generic, okay? Everything in your book is listed as generic, so that's why I do that. And I think it's easier with generics because if you learn that last the tides or the GLP-1s and the, flosins or the SGLT2. You learn that ending, like in blood pressures, the LALs or the beta blockers and the things like that, then I think it's easier for you to recognize the medication than if I say Trulicity or Tanzium. There's so many T's right now. There's Trulicity and Tanzium, a bunch of them. I get them all mixed up. So I think it's easier to do the generic. It's a weird question, but are there any problems can work out to get used to doing this? Do you have any extra questions you could share for the insulin carb ratio and the correction factor? Is that what you're asking, Alexa? Yes. Okay. I can put some in there. I can put some in the form for you. And let's see. For testing, are we expected to know which meds to add for dual and triple therapy? Basically, yes. You need to know that you start with metformin and then you add another if they're not at goal. And how long do you wait after you start a medication to decide that it's, do their A1C again and make a change? 3 months, okay? I just listened to a presentation on, I think it was on that soliloquy or whatever, soliloquy, a couple days ago on CME, and it was a video presentation, and they said the average time from diagnosis until adding anything other than metformin in this one study was something like 18 months. And I see that all the time. I see patients that just are on metformin and their A1C is 9, and it's called clinical inertia, where providers just kind of, first of all, they don't want to mess with it, or they don't really know what to do, and they just kind of ignore it. And so every 3 months, you should be looking, and if they're not at goal, thinking, what can I do to improve their A1C and get them to goal? What kind of, how can we change their regime? So, you do need to know what would come next. And it, like I said, it's not a cookbook. You can't just say automatically, it's A and then B and then C. It's any one of those classes. It's an SGLT2, it's a GP4, it's a GLP, it's a sulfonylurea, depending on the individual patient, their needs, their resources financially, their ability to give themselves an injection, their other comorbidities, a TZD. Well, if they have congestive heart failure, you don't want to give them a TZD. If they have heart disease, you may want to give them the Victoza and pegogliflozin. So, and know which ones to add. Yes, you should know which ones to add if they have cardiovascular disease, and that's really just the Jardiance and the Victoza, which are, I'll give you the generic names. Victoza is liraglutide, and Jardiance is pegogliflozin. So those two, both in the last year, have gotten FDA indications for showing a cardiovascular benefit in patients with type 2 diabetes and arteriosclerotic cardiovascular disease. So you should know those. Okay? Okay. Anything else? Sorry it took so long. This is always a long lecture. This one and the cardiac one in the summer are long lectures. So, okay. And try to have your questions in the forum by Friday. I'm going to do a race this weekend and spend a little time with my family. So I'll try to get my questions answered before the weekend. And good luck. Well, this one's not a serious race. I did a 4-mile race last weekend, and this one's just a 5K, but it's more of a fun run. So it's not too bad. But thank you. Okay, and I'm glad my lectures are helpful. I hope that's the purpose. So I get out of breath thinking about 4 miles. Yeah, but one step at a time, you can still get there. Okay. Okay, I'm going to go ahead and sign off, and if you have any questions, put them in the forum. Thank you very much.